Trust these rules because the rules have been established and they're always going to play a role. So we're talking about the first 24 hours, of 24 to 48 hours, excuse me, of a burn is known as the emergent phase. Okay? And there's certain things that you guys have to be very aware of during the emergent phase. First of all, ABCs is always priority, right? We get that. ABCs is always priority no matter what, airway, breathing, circulation. But what happens in this phase is going to be a potential for hypovolemic shock. Now, can you guys tell me why the patient that has a burn, oh, by the way, for these elements that I'm discussing, for them to be a potential issue, there has to be a body surface area of at least partial thickness, meaning at least affecting the dermal layer also, of 20% or more. Now, I want to elaborate on this, okay? What this means is that if your body surface area of the patient is 10%, we're not going to have these problems. And this is in theory, okay? In the real world, who knows what might happen. If the patient has a 15% body surface area, that's all the way down to the full thickness burns, like the 3rd degree, they're not going to have these issues that I'm about to talk about because they must have a body surface area burn of at least 20%, and it has to be at least partial thickness, which means at least the 2nd degree burn, because what do we have in the dermis that we do not have in the epidermis? Blood vessels. And if you burn 20% of all those blood vessels, you've just disrupted your perfusion, your hydration, and you've lost almost a quarter of your body's fluids. That's why these issues might be a problem. Does that make sense, guys? So consider that all these things that we're about to talk about can happen when it's like that. Okay, so that's why the patient may develop hypovolemic shock. You must assess for hypovolemic shock. Sometimes the patient will have a Foley catheter inserted so they can keep an eye on the urine output. You must give them fluids, usually Ringer's lactate, or lactated Ringer's, however you want to call it. So you have to look out for hypovolemic shock, tachycardia, hypotension, things like that. Does that make sense? Another thing that might happen during this phase of the emergent phase is the patient may develop hyperkalemia. Okay? Hyperkalemia is high potassium level, but why do you think that might happen? How is the patient going to have high potassium level? Any idea? If you can imagine all of your cells being destroyed, right? You have all your cells. The most abundant electrolyte inside the cell is potassium. So what ends up happening is, if you're destroying those cells because of the burn, they're releasing all the intracellular potassium into the intravascular space, meaning inside the vessels. And that's why your potassium will go up. Does that make sense? Okay. So these are the most common issues that happen during the emergent phase. As you're transitioning from 24 to 48 hours, a little bit more, still within this emergent phase, you have one more thing that I forgot to mention. You're going to place an NG tube on the patient. You guys have any idea why? No, because this is G tube, right, for the stomach, not the airway. But the reason why we're going to do this is because people that have these type of burns, their body's very stressed out, you're losing your fluids. We need fluids to create mucus, right? And saliva and all that stuff. And we need that stuff to protect the inner lining of our stomach. Also, when you're very stressed out, it puts more stress on your body, and you could develop Curling's ulcer, is what we call it. So Curling's ulcer is a type of ulcer that you develop inside your stomach, a gastric ulcer, and it's secondary to burns. So you have to know that this is specific for those type of, it's that type of an ulcer that's caused by a burn. And so because of that, you put an NG tube to decompress, to remove the acids from the stomach so it doesn't further exacerbate the ulceration. Does that make sense? Okay. With that being said, we transition from the emergent to the acute phase. And the acute phase is going to be from 48 to 72 hours, right? Now, a lot of things can happen when somebody has burns, but the main focal point of this particular area or time frame is going to be a potential for infection. Most people that develop infections when they have burns, they do so in this particular phase, in the acute phase, from 48 to 72 hours, because that's when the bacteria can enter the body and then proliferate and cause the infection. So it takes a while. Does that make sense? Any type of wound care that we do for these patients, we must use surgical asepsis, okay? Sterile asepsis, right? During this phase of the acute phase, hypovolemic shock did not kill the patient. So we have something called fluid resuscitation. Fluid resuscitation means that the patient survived the emergent phase. They didn't die because of the hyperkalemia, they didn't die because of the hypovolemic shock, and now the fluid that left the vessels into the tissues are returning all the way back into the vessels. And so they're reestablishing hydration of the vessels. Does that make sense? So we call that fluid resuscitation. It's what's supposed to happen. During this phase, you're gonna have polyuria. Because all the fluid is returning back to the vessels, your body has a new abundance of fluids, and your kidneys are doing its thing. The problem is, you may have to be careful with, again, dehydration, because the fluids are going back to the vessels, but if you're not giving them fluids, then they lose the fluid that they are putting back in the vessels, and they're peeing out. They're not being replaced. So we must continue the fluid administration. Does that make sense, guys? So we must continue the fluid administration. Keep an eye on the Foley catheter. Make sure that the urine does not get too concentrated, because that would indicate that the patient is dehydrated. Makes sense? Okay. Let's see, what else? Oh, hyperkalemia. Your heart may stop pumping because of this, right? You may develop asystole. So there's different ways to fix this. You don't want to give them diuretics because we already know that they might develop hypovolemic shock in this phase, right? So you give them something called sodium, excuse my spelling, but it's polystyrene. I'm pretty sure, let me see. Yeah, that's a bad spelling, but it's also known as Kyaxalate, or sodium polystyrene is the medication that you drink and it helps you poop out the potassium. It's also known as Kyaxalate. Okay, how do you spell it? I'm hopefully looking it up. I want to make sure I spell this right.
It's Polysty.
T what?
Ty.
T-Y.
R-E-N-E.
R-E-N-E. Not as bad as I thought it was. So sodium polystyrene, that's Kyaxalate. A little brown solution, it smells sweet. Don't know what it tastes like, but you drink it and it helps you excrete potassium. So that's another way of losing potassium. And right now we're just exploring ways of reduction of potassium, okay? Another way to reduce potassium that you guys have to know is that you have your cell, right? And you have too much potassium in the blood, outside the cell in the bloodstream. What we want to do is we want to get that potassium inside the cell. So what we can do is we give insulin. Because insulin, we know that insulin pushes sugar inside the cell, right? But it does so with the help of potassium. So every time you give insulin, it will also help push the potassium from the bloodstream, which is a hyperkalemic issue, into the cell, which will reduce the serum potassium level. But you must give the patient, when you're giving them insulin, you must also give them dextrose or sugar, because we also know that the blood sugar is going to drop, even though that's not the intended purpose. We're trying to reduce the potassium, but we know insulin lowers glucose also, so we must give them insulin and glucose to reestablish or to maintain that glucose level. Does that make sense, folks? Okay. When you have burns like these also, you must consider circumferential burns. I talked about that a little while ago, right? The circumferential burns, the problem is that the blood flow is going to be compromised, because if my entire arm is burnt all across the circumference, then that means what happens when you get a piece of steak and you slap it on the grill? Sometimes it's this big. But what happens to the carne asada, preparada, ranchera, all that stuff? What happens to the size? It shrinks. So your skin does the same thing. Now imagine if you have a burn that goes around here, it's going to shrink and cause compartment syndrome. You follow? So in those circumstances, we must understand that they may undergo an esclerotomy. And the esclerotomy is where they cut into the tissue down to the fascia so it can relieve the pressure and the circulation can be improved. You can do that on the thorax too. I've seen patients who have their entire thorax burn, the circumference, and they must cut into it so it could stretch out, and then the patient will be able to breathe better and the patient will be able to have better circulation. Does that make sense? Okay. These are, in a nutshell, the most important concepts for the burns. And I know it's going to be hard to memorize all this stuff, but we're going to use this as a foundation, and I'm recording it so you guys will watch it later on as well, so we can answer these questions with burns. Okay, folks?